It's my pleasure to speak with you this morning about kinematic alignment and computer navigation. These are my declarations. I'd like to start by giving a few definitions. What's in a name? I'm obviously referencing Sam Usadek's January Bone and Joint Journal article about nomenclature when speaking about alignment in total knee replacement. And you can see these different terms. I think I probably only know what one of them actually means if you told me that's what you do. And it's because there's so many different things that we're trying to correct. Constitutional limb alignment, joint line obliquity, joint line congruence angle, soft tissue ligament tension, soft tissue muscle vectors, gait parameters being corrected. It's quite confusing. And when I think about not just the kinematic alignment, but general alignment spectrum in total knee arthroplasty, I think it would be much easier if surgeons decided that if they're going to do mechanical, then they're aiming for a 0 HKA and not deviating from that. And that if you're going to be doing a pure kinematic resurfacing, it might be better if we describe that as anatomic alignment. And then anything in between, your restricted boundaries, your adjusted mechanical, it'd probably be best if those were termed functionally aligned knees. And most of the time, if you do a functionally aligned kinematic knee, you can actually do a pure resurfacing because most of the HKAs that we're dealing with are within a reasonable boundary, 3 degrees of residual limb varus. You'll probably get about 85% that are within 6 degrees of residual limb varus. And if you want to use virtual gap balancing on top of those alignment methodologies, you can say I do an anatomic resurfacing or anatomic kinematic alignment with virtual gap balancing, or use the term functional positioning. As for computer navigation, at its simplest, it can precisely perform desired cuts. I don't think anyone can really argue that it's a very precise tool. It reduces outliers in the coronal plane. And at its most complex, it can virtually gap balance a knee. I think most people probably still use computer navigation just to perform cuts accurately in a mechanically aligned knee. But if you're going to do a kinematic knee, how do you know what your endpoint is? You can start in 6 degrees of varus. Do you correct to 2, 3, 0? How do you know? So I'd like to speak about the arithmetic HKA, which my two partners, Sam McDessie and Darren Chen, created earlier this year. And I'll start by an example. Here we have a 4-foot film demonstrating grade 3-4 changes in the medial compartment on the right side and grade 0 to 1 on the contralateral left side. I think most surgeons are familiar with the HKA. I'll call it the mechanical HKA. It's the angle subtended from the mechanical axis of the femur to the mechanical axis of the tibia, and it looks like this. The AHKA is a calculation, and it's created by subtracting the LDFA from the MPTA. You can see the angles of the MPTA and LDFA drawn on the arthritic knee. And if we substitute the numbers in, the MPTA was 86, so there's 4 degrees of proximal tibial varus, and the LDFA was 88, so 2 degrees of distal femoral valgus, which gives us -2 degrees of residual limb varus. And if you care to guess what the mechanical axis was on the unaffected side, yes, it was in fact 2 or 2.3. And in this study, they showed that the AHK of the arthritic knee could predict the MHKA of the normal knee within 0.4 of a degree. They then went on to use the AHKA to create a restrictive boundary kinematic protocol and quantitatively assess the soft tissue balance in those kinematic knees versus mechanically aligned knees in a randomized controlled trial. They used OrthoSensor's VariSense to look at intercompartmental pressure differences between the medial and lateral compartments. And they showed that these kinematically aligned knees using the AHKA had a markedly reduced pressure differential between the two compartments. That is, the knee was more often balanced, and that was through the entire range, most notably in extension. And if you were going to then balance these unbalanced mechanically aligned knees, they required bony recuts in 49% of them to achieve that pressure differential less than 15 psi. That is quite significant. So in conclusion, I think that computer navigation is critical to precisely recreating bony native alignments when used in conjunction with AHKA to define your endpoint. Thank you very much.